It's my privilege to introduce Dr. Ganesan, Associate Professor from KAPV Government Medical College, Trichy. Right now, he was a President ISA Trichy since 2002, and he was a Secretary ISA Trichy 2014 to 2022, and he was the Organizing Secretary and a Vice Chairman in different forums, and he is a faculty in Preeti Anesthesia Update in the year 2020 and 2022, and Sir has done many publications in reputed journals. And it's my pleasure to introduce Dr. Rajesh, Senior Consultant, Anesthesiologist and Pain Physician, Meenakshi Mission Hospital, Madurai, and he is a faculty for DNB Anesthesia since 2006 and faculty for DNB Critical Care since 2017. Sir is an eminent faculty for many workshops and conferences, and he done multiple publications in reputed journals, and his area of interest is pain medicine, regional anesthesia and USG guided interventions. We happy to have them here, sir. And I also extend my privilege to welcome Dr. Vail Murugan, Professor, Madurai Medical College, Secretary of ISA Madurai City Branch. Sir has delivered many lectures in anesthesia and orthopedic conferences on airway. Then he also published many papers in various indexed journals, and he is practicing regional anesthesia and pain for more than a decade. It's my privilege to introduce Dr. Narasimhan, Associate Professor, Department of Anesthesiology, Stanley Medical College, Chennai. Sir has been appointed as a faculty in many workshops, and Sir has presented a many number of lectures and conducted workshops organized by Stanley Medical College. He has done more than 7 publications in reputed national and international journals. And I'm happy to introduce Dr. Prem Kumar, HOD and Senior Consultant of Anesthesia and Pain Management, Mehta's Hospital, Chennai. And he has done 2 international and national publications. Sir has been a reviewer in Indian Journal of Clinical Anesthesia and conducted many workshops in USG guided regional anesthesia and chronic pain across the country. We are happy to welcome you, sir, here. And I also would like to extend my warm welcome to Dr. Rajaram, sir. Currently, he is working as a Senior Assistant Professor in Stanley Medical College, Chennai, and he is a renowned faculty for many regional anesthesia workshops and conferences. He is actively practicing regional anesthesiologist. Here I am going to introduce Dr. Sendil Kumar, sir, the Associate Professor, Department of Anesthesiology, KAPV Government Medical College, Trichy. Sir has served as a faculty at state level conference at Madurai in 2012 and faculty in state ISC conference at Coimbatore, which is conducted in 2018. And he is a quiz master for the South Zone Conference held at Trichy in 2017. He is also serving as an organizing team of many conferences and workshops. We are happy to welcome all the panelists on stage.
For guiding this dynamic discussion, we have an esteemed moderator, Dr. J. Balavenkata Subramanian, President-elect, World Federation of Societies of Anesthesiologists, immediate past President, Indian Society of Anesthesiologists, National Academic Head, Senior Consultant, Ganga Hospital, Coimbatore. Sir, we are honored to have you to moderate this session. We kindly invite our respected Chief Guest, Dr. J. Balavenkata Subramanian, and our panel members to take over the session.
Good evening to everyone. At the outset, I would like to extend my sincere thanks to the entire organizing team of Preeti Hospitals, led by their CEO and Chief Orthopedic Surgeon, Dr. Shiv Kumar sir. I think he is attending his national conference in Guwahati, and hence he is not here. And the entire team of Department of Anesthesia here, led by Dr. Balaji, Dr. Suresh, and all the consultants of Department of Anesthesia. Extremely happy to be here as a part of this 2-day program on regional anesthesia, in specifically to the upper extremity blocks. How many of you here use ultrasound in your clinical practice? Can you please raise your hands? That's excellent. Okay, very good. So we will directly dive into the scenarios, and we are so happy to have a rich panel of experts who have doing their clinical work day in and day out. But the last decade has seen a complete revolution in the practice of anesthesia. And as I always have been sharing my thought, that this is the era of anesthesiologists adopting new technologies to give the best to the patient. And the surgeons have started clearly deciphering the difference between an anesthesiologist who's extremely competent to do a block versus the one who cannot. And it's becoming prudent that the clinical practice of many of the surgeons are becoming better when they have an anesthesiologist who can offer excellent quality of regional blocks for two reasons. One, even a very highly complicated surgery can be made very easy. Number two, whenever you incorporate regional analgesia as a part of your overall, even if you give general anesthesia, if you add regional anesthesia as a component of multimodal analgesia, the patient is extremely comfortable in the post-operative period, and the surgeon feels extremely happy to see an awake, painless patient in the immediate post-op. I'm part of the Ganga Medical Center and Hospital, Coimbatore, and I'm happy to share that we started our nerve blocks way back in 1998 with peripheral nerve stimulator to start with, graduated to ultrasound in 2008, and now there is not a case which goes without a block. So now we have over 38 operating theaters, 90 anesthesiologists, 150 surgeries a day, and we have about 18 ultrasound machines dedicated to the Department of Anesthesia, and this has completely changed the way anesthesia is being practiced in the perioperative period in our institution. For all the youngsters who are present here, we also take this, I take this opportunity to welcome you all. If you wanted to do a fellowship in regional anesthesia after you complete your graduation, you're most welcome to join us. And I will give an example of why this CME is important. Why should you start thinking about becoming very proficient in regional anesthesia and analgesia? So here comes a patient. This is not an upper limb case, it's a lower limb case, but it's a real case. And I just wanted all to get into the groove of why you need to focus on this session today and what difference it will make to you in your clinical practice. Here is a 42-year-old male, hypertensive, diabetic, coronary artery disease, triple vessel disease, angio-approved. All the vessels were more than 80% block. Advised coronary CABG, and patient family refused because when in the consent form it was written there was a possibility of perioperative morbidity and significant mortality. So they didn't sign. They want to preserve him, so they went for medical management. And he was also obese, and he had a deep vein thrombosis 6 months before, and he was on anticoagulants. And because of the coronary artery disease, he was on antiplatelets. So he was also hypothyroid. He was on thyroid replacement, and he had his lunch, fell down in the washroom, sustained an ankle fracture, which was open. And when he came to our hospital, his BP was 240/120. And now, as you know, that most of the anesthesiologists who started using ultrasound have also become experts in point-of-care ultrasound. So we did the echo. It showed a EF of about 38%, and worse, he had an aortic stenosis. His INR was 2.3. Now, what should we do? Cardiology opinion, diabetology opinion, pulmonary opinion, internal medicine opinion. You can ask for 8 opinions. But in the process, what you achieved? Nothing. And each consultant will come and write whatever they want without even seeing the patient. And eventually, this patient is going to suffer because he was writhing in pain. And if you part of this program, this course, with a clear take-home message, I think what you will definitely do is something very pertinent. So we'll tell what we did. High-risk consent, inform the family and the patient about, they knew it already, but எப்பவுமே கேட்பாங்க அப்போ ஒன்றும் ஆகாது இல்லைங்க அது பரவாயில்ல அது எல்லாமே கேட்டுட்டு they'll say ஒன்றும் ஆகாது இல்லைங்க. So you now when you use ultrasound ஒன்றுமே நிஜமா ஆகாது. That's the biggest advantage of going for site-specific anesthesia. So INR 2.3, dual antiplatelet therapy, EF of 38%, severe aortic stenosis, 240, 120. The sugar was 340, and urine acetone was positive, and now he comes with writhing pain. So written consent, knowing the issues well, if you are very proficient, discuss with the orthopedic surgical team and the patient, take them into confidence. So all that he got was an ultrasound-guided popliteal sciatic block. That's it. And 20 minutes afterwards, what happened to the blood pressure? Because now you produced pain relief, and BP came to 140/80. Heart rate, which was 120, became 80. And patient became numb. And the orthopedic surgeon did a close reduction because there was profound swelling of the ankle fracture. So close reduction was done, slab, limb elevation, and you can't stop any of the drugs because he has got a significant coronary artery disease. And he had a previous history of deep vein thrombosis. So now, except for stopping the warfarin which he was on and getting the INR back to normal, after 5 days when the swelling went down, a repeat block and the ankle was fixed. Now, why I wanted to present this case is to show that each of you can become indispensable in a hospital because of your ability to convert a ASA grade 5 patient or a ASA grade 4 patient into grade 1 patient because of your capacity, capability, technology, and technique. Do you agree with me? So I want each one of you present here to consider today and tomorrow as an important tool to think of making yourself as competent as you can with all the panelists who are present here, and make sure that you embark on a journey from Monday when you see a case. You need to see how you can do the case irrespective of the surrounding issues that he has, so the best benefit goes to the patient. That would be what really we wanted to convey in these 2 days. And similarly, initially it was thought regional anesthesia is only for providing anesthesia, upper limb block, give a block, do the procedure. But now, regional analgesia has become a part of multimodal analgesia in all our spine surgeries, especially the scoliosis surgery, which goes for about 4 to 5 hours, lot of tissue injury. At the advent of erector spinae block, which is a simple block, if you give a 4-quadrant erector spinae block, target controlled infusion, TCI we use, we don't use relaxants, we do the spinal cord monitoring, MEP, SSCP, and with the new machine, though I don't want to promote it, but the new machine, the Arcomed, the TCI pump has got 16 formulas. So you can choose based on pediatric case or it's an adult case, you can one of the formulas you can choose, and you can do the whole case under target controlled infusion with 4-quadrant erector spinae block with BIS monitoring. And believe me, at the end of the procedure, it is so tailor-made anesthesia, precision, perfection to the core. After 4.5, 5 hours, prone to supine, patient awake, extubated on table, and pain-free, where regional became a part of multimodal analgesia. So even if you give general anesthesia, you need to consider using regional analgesia as a part of multimodal for excellent quality of pain relief. And is it only for the pain relief? I will finish with this before we go on to the panel. It's just not the pain relief, but the internal milieu becomes very different. Because when you do a regional analgesic block, when there is a tissue injury, there is pro-inflammatory cytokines that are released into the blood. And this pro-inflammatory cytokines result in increased nociception of the nociceptors, producing significant pain post-op. Now, when you do a regional block, this reduction in the production of pro-inflammatory cytokines helps in decreased peripheral sensitization and central sensitization and an excellent outcome post-surgical patients. So the advantages offered by regional seems to be huge. So please be a part of the journey and think that each one of you should master regional anesthesia techniques and make a huge difference in the outcome. Get your surgeons addicted to you, and they should come and ask, why didn't you use the block for this patient? You should addict them and make them a part of the process. And now we will go to the first case. Dr. Balaji will present the first case.
Thank you for your valuable insights, sir. Sir, at the outset, I just want to announce that we are very proud that it has been made official that Sir has been unanimously selected as a president-elect by the board of WFSA. And I think this is the first conference he is attending as the president-elect of World Federation of Society of Anesthesia. So I think this is a very proud moment for all of us.
Thank you. Thank you so much.
Sir, we will start with the first clinical scenario. This patient is a 50-year-old female, came to our center for a both bone forearm fracture. She is a known diabetic, systemic hypertension on regular drugs. She is a known obstructive sleep apnea patient on home BiPAP therapy. She has a BMI of 42 and her cardiac evaluation shows normal chambers with adequate LV function, mild pulmonary hypertension, and there are no features of suggestive of car pulmonary. The patient has been posted next day for open reduction internal fixation with plating for both bone fracture forearm. Written consent explaining the high risk for anesthesia and surgery was obtained. Need for post-op ventilation and BiPAP therapy were also explained. The initial plan was ultrasound guided supraclavicular block with an 15 to 20 ml of 0.5% bupivacaine was planned, and the block was given successfully. But post-block, the patient complains of pain even after 30 minutes of block, and on evaluation there were no sensory or motor blockade present. So now I ask Dr. Senthil Kumar Mohan sir to guide us how to proceed further in this scenario, and Bala Venkat sir to moderate the session.
So once she says the technical skill, probably they never put the drug.
And 20 ml of drug, definitely it should act.
So
if the anatomy is
so according to Dr. Shereen, so volume has not been a problem.
Yeah.
Drug is not a problem. So they have chosen 0.5% bupivacaine. That is perfect. The volume offered is perfect. Supraclavicular approach to brachial plexus is perfect for a forearm fracture. All these three are good, but the block didn't work. So one, she feels that it could be a problem with the technique.
And sonoanatomy, like might be variation, anatomical variation. They are not aware of that variation.
So sonoanatomy has been different. Any other answers? Okay, now maybe request Dr. Senthil to come forward and share his thoughts. And if this happens, now I'll probably randomly choose. I think I'll start from here. What's your name, doctor?
Dr. Vasantarani.
Doctor?
Vasantarani.
Vasantarani.
Yeah.
So you use ultrasound guided blocks?
Yes, sir.
Okay. So this is the scenario. You are the anesthetist. Block did not take. What will you do?
I'll repeat the block.
Repeat the block?
Yes.
Okay.
Or
Yeah. So if you are going to repeat the block, what are all your concerns?
Toxic dose of local anesthetic.
Excellent. Toxic dose of local anesthetic solution. So now so now this, we will consider that this case is probably 60 kgs.
Okay.
And she's 50 years, 60 kgs, diabetic. Okay, so we had given about 20 ml of 0.5% bupivacaine. Now, how will you decide on the next dose that you want to give? And when you said it's about toxicity, what does your mind say?
Sir, already we have used 20 ml.
So 20 ml of 0.5%.
Yes.
So how many milligrams we have used?
600. 400 mg.
So it is 0.5%. So that's 5
Sorry,
milligram per ml. So 20
100
ml.
100 mg.
So you have used 100
100
milligram. Now, what is your thought about the toxic dose of bupivacaine?
Maximum 300.
Per kg body weight.
So bupivacaine with adrenaline we can give 3 mg per kg, sir. So 5 mg per kg, sir.
So
Without
are you sure on what you're talking?
Sir, 3 mg per kg, sir.
Okay.
So maximum.
So it's 60 kgs. So we'll take it as 3 m. So it's 2 to 3 milligram per kg body weight. So if you take it as, it's not with adrenaline, they're given without adrenaline. So 2 to 3 milligrams means if you take 2 milligrams, 60, 120 milligrams. So you have only 20 milligram left.
Yes.
Is this right?
Yes, sir.
So what does Dr. Sendil Kumar wanted to say?
Thank you, sir. Probably I think we have got the initial response from the audience, so that I will expect more participation from the audience. First of all, just summing up this case scenario, there are only 4 points that I like to get from this case, right? All the first, among the first 2 lines, the most important line regarding performance of the block is the BMI, right? So obesity is a definite concern when performing in ultrasound-guided regional blocks, because the anatomy is tough, or the fat definitely makes the sound rays less, target structures less visible. Obesity is a problem for everybody, right? Being spinal, G, everything is a problem. So even regional anesthesia, obesity is also a problem. So all other things are immaterial for me if I am competent in doing a ultrasound-guided regional anesthesia. Obesity is definitely a problem when I do a ultrasound-guided block. The second important point is the nature of the surgery, right? They're doing a fracture both bone forearm. So the first thing that comes to my mind is, which block should I choose that will be relatively safe, that can have a good success rate? Meaning, with the ultrasound, through which I can see the brachial plexus component very clearly, without any problems, including locating or seeing the needle. It's not only about the sonoanatomy. Remember, not just seeing the brachial plexus is important, depositing the drug around the brachial plexus is most important. Like giving a spinal, seeing the CSF flow is not important, depositing a drug within the CSF only makes the anesthesia. So it's not only the sonoanatomy, remember, needling also plays a very, very important role. So for this case, definitely supraclavicular brachial plexus block was given. It could have been avoided also, because being a fracture both bone forearm, very well could have been done with a costoclavicular block, even as simple as a axillary brachial plexus block. Remember?
Dr. Sendil Kumar, if you are given a choice again in this particular patient, which one will you choose, a costoclavicular or supraclavicular?
Definitely costoclavicular brachial plexus blocks.
Why do you think that's better?
Because what I feel is costoclavicular brachial plexus block, locating the needle is much more easier, because the beam goes almost perpendicular or very straight to your brachial plexus contents. Unlike your supraclavicular, being an obese, where a short neck will be there, I need to insinuate the probe very caudal towards the fluid.
So how many of you here have given costoclavicular plexus block? So hardly any. So tomorrow in workshop, I think costoclavicular should be put a lot of emphasis on costoclavicular. Yeah, okay, over to Sendil.
Yeah, the second thing is, what I would like to have is probably the drug is not an issue. People, because institutional protocol, my advice, bupivacaine, that's not an issue with me. And all other things regarding the OSA, home bypass therapy comes into my mind when there's a failure. Definitely, you cannot manage a failed block with sedatives. Sedatives means usually the common tendency is giving ketamine, a mild amount of sedation. No amount of sedation or can manage a failed block. Sedation comes into play only when the patient is anxious, when you know sure the block has taken. A partial block, a sedation cannot replace a partial block. Remember that. So if it's a failed, it's failed. Accept your failure, learn what is the cause of the failure, then proceed. Right? Then the reason for this, probably the block is, the main reason for what the failed peripheral nerve block in this case could be, the first step is your image acquisition. The second step is image optimization. What I mean by the optimization is adopting the correct depth, correct dynamic range, correct focus, and the gain. Right? That all these things will teach you tomorrow. No, don't worry. These are the steps. The third step is target identification, meaning which is my target, what are structures to be avoided, what are structures I need to block. What could have probably occurred in this case is the last two, meaning the needle to target guidance and visualization of the local anesthetic deposition. These two would have been missed in this case. Probably they have seen the sonoanatomy, they have seen what are the plexus, whereas they do not see the needle or they do not see the local anesthetic deposited around the plexus or the target. So the last two component is most important. As I said before, the fifth component is the most important for the block to take up. Unless until you see circumferential or 360-degree spread of local anesthetic around your plexus. For example, in this case, around the superior trunk, middle trunk, and the inferior trunk for a supraclavicular brachial plexus block, your block will not take up. So that, I think, is the most important cause for this patient, I think.
Dr. Sindel, what if you wanted, some of them are very new, they've not done enough blocks, but they've learned to acquire the image. For block success, do you have any other suggestion that you want to give them?
Probably the tips, one thing is positioning of the patient.
No, I mean to say an additional gadget.
Probably
Yes.
now
As
stimulator.
Dr. Ganesan said, best is in the initial phase, if there is a peripheral nerve stimulator that is available, I think best is to go for a dual mode. You will identify with ultrasound. It looks like plexus, but now you set a low current of 0.5 milliamps and go towards that and look for the appropriate contractions. So now you will definitely not miss. So to minimize the failed block in the initial phase of your career, or when you are confronted with an ultrasound machine which is not giving good resolution, I think we can consider going in for a dual approach to brachial plexus. And one more important thing which Dr. Sindel mentioned is it's a forearm fracture. So I want all of you to tune your thoughts into the concept of dermatome, myotome, osteotome. So when a surgeon fixes a forearm fracture, what are the dermatome, myotome, osteotome that will be that needs to be blocked, and you choose an approach which will block all the three. And in that, the options are for a forearm, it could be a supraclavicular approach to brachial plexus, costoclavicular, infraclavicular, and even axillary. If you think it's very obese, and in costoclavicular you have to abduct the arm, and if you are not sure, even you can go for an axillary block to give an excellent quality of analgesia. So that's the other point. And Dr. Sindel, what do you think about a repeat block, which they told, and the volume to be used? That's the next important question of toxicity. What are your thoughts on this?
Definitely, that's $1 million question. That depends upon case to case scenario. Probably in this case, being a very high risk for GA, general anesthesia, if I'm sure, probably I again like to scan the area where the drug has gone. Like whether they are really, definitely they have missed the supraclavicular area, that's why the block did not take up. I like to again scan, definitely drug is not there, probably I'll go with the 0.25% bupivacaine. Since that's almost 3 milligram per kg comes 180 milligram, I still have around 80 milligram of bupivacaine. Probably I'll go with the axillary brachial plexus block so that I can block the individual nerves, the radial, medial, and this thing.
And now I throw open this question to all the panelists. So, this is a very important discussion which I want to make regarding the repeat block. So, now we know that in the textbook description, bupivacaine toxic dose not to exceed 2 milligram per kg body weight. The lignocaine 4 milligram per kg body weight. Lignocaine with adrenaline 6 milligram per kg body weight. Agreed? Yes? Okay, now the next question is, how did people decide 2, 4 and 6? On what basis? So if you go to the parent article, it is all on human volunteers that the drug was injected in the epidural space. And then the plasma volume was, in the plasma levels of the local anesthetics were checked. Most of the initial studies which defined this are done like this. Now the question is, the rate of absorption of the local anesthetic solution from different parts of the body are different. The epidural space, the rate of absorption is 10 times higher than the brachial plexus. So now what it implies? Do not really worry about toxicity until otherwise you have placed it intravascular. So according to me, and my suggestion is 2 milligram per kg body weight was for the epidural space. 1/10 of that absorption in the brachial plexus region, so which means you can be comfortable to use adequate volume, and I personally feel that you should go only for 0.5% again, because 0.25% may not, because this is a sole form of anesthesia. We are not going to give general. We want a good motor block. We want a sensory block. My idea and my suggestion would be to go for one important point is you locate the nerve and place it around the nerve. And if you do it very well, even 15 ml, 12 ml to 15 ml is absolutely sufficient, but provided the tip of the needle is very close to the nerve and the drug spread, as Dr. Sendil mentioned, encompasses the nerve. Then the volume, so you can use a minimal volume, but I want to take away this myth of toxicity when you repeat a block, because the rate of absorption is less, and you can definitely go for an adequate volume to give the block. Because here, we are not talking only theoretical aspects, we are also knowing that the surgeon is waiting to do the case, 30 minutes already lost, and another, like if you are going to give a lower volume and then you wait for the block, by the time the surgeon would have made a decision that next time he is not going to call you. So we need to be practical also. So this is a point which I wanted to share, and I want the opinion of the panelist.
Regarding that visualization of local anesthetic deposition, and Dr. Sendil mentioned, post supraclavicular brachial plexus block, it's better to visualize the drug in the costoclavicular space. Whether the drug has reached the costoclavicular space, it gives us two ideas. One thing is, if the drug has partially been injected into the supraclavicular space, the costoclavicular space identification will become much more easier when we have a failed block like this, and we can repeat it with the lesser volume there at the costoclavicular space. And the second thing is related to the peripheral nerve stimulator along with the ultrasound. I always recommend usage of a peripheral nerve stimulator at least at the level of 0.5 milliamps, so that we can avoid neural injury, because it becomes a common tendency when you see the nerve, you go very close to the nerve and injure the nerve. So if there is a twitch at the level of 0.5 milliamps, better not to give the drug when you can see the needle is very close to the nerve. So in that angle, I think peripheral nerve stimulator adds up much more safety related to the blocks.
So has been, so two things, dual. So sir says that low current, 0.5 milliamp, identify the structure, 0.5 milliamp, and now we have got one more additional thing that's called the third component. Now it's called three things in one, and that is the injection pressure monitor, which is now commercially available. Initially, it was only Pyank, which then it was B-Smart, And now Turin company has come up with when you use an injection pressure monitor, this particular issue never comes, like injuring the nerve also never comes. So when it comes to safety, ultrasound with PNS with an injection pressure monitor. Point very well taken, sir.
Yeah.
Prem?
Yes, so in this patient, I think the audience is more concerned about repeat block, whether we can do a repeat block or not.
So the answer is yes.
Yes, absolutely. So having practiced in regional anesthesia for so many years, if the same thing happens with residents, as a consultant, I would always tell them like, yeah, you can definitely go ahead. As Sir said, the rate of systemic absorption in brachial plexus is very less, unlike an intercostal block. So I would not hesitate to again repeat the same block again with the same volume, but as with a, if at all a consultant is there, yeah, I would have supervision so that I know where exactly I'm depositing the drug, so that the second one would be successful.
Excellent, Dr. Prem. So I'm noting the timing also. So the take-home message of this case, number one, can block failure happen? Answer is yes. Number two, can you repeat the block? Answer is yes. Number three, you can use adequate volume in brachial plexus because it won't produce toxicity. Number four, an important point Dr. Sendel said, in an obese patient, sleep apnea, you don't want to, without an airway that is protected, you don't want to use any sedation for fear of hypoxia, aspiration. So in case if you decide not to repeat the block, the next course of action is to go for a proper general anesthesia with an airway protected without taking any risk on this patient. So these will be your take-homes. And the next important thing is we will attend another regional anesthesia workshop to make sure that you get your sonoanatomy properly. Right. Dr. Sendel, any closing remarks on this case?
The important point, especially with regard to the supraclavicular brachial plexus block, is identifying the lower trunk. Most of the time, being this case is totally, they have missed it totally. If in case, most of the time in supraclavicular brachial plexus block, we usually have a partial block. So the main reason for it, usually what we see is the bunch of the grapes adjacent to the artery. That's the thing. You see something white and black and white something, go and deposit the drug, you think the block is going to act. That's not the case. Identify the lower trunk, see what is the bunch of the grapes. Decode what is the bunch of grapes, then deposit the drug.
So the corner pocket injection.
Exactly, sir.
So today you will go and refer the Google search on corner pocket injection. And primarily, this session was to make sure that your thought process is on how to handle a case when there is a block failure. And also, always be very transparent to your surgical colleague and tell him that the block didn't work. So, they have to believe you, and they will slowly will support you, but be very truthful to the surgical colleague that it didn't take. Yeah.
Can I repeat a supraclavicular block, or is it advisable to go for infra or axillary block? Question number one, sir. Question number two, can I add adrenaline to the next injection I'm making, or shall I use lignocaine with adrenaline?
So the first question is, when I repeat a block, whether I go for above the clavicle or below the clavicle. Now, the most important thing is, you should know the block that you are doing. Theoretically, as we said, it can be done with infraclavicular. The question possibly arose from the fact that if you place some more drug, whether it will produce a phrenic involvement, and in a patient who is having OSA. But the point is, the first block didn't act at all. So I think it is nowhere near the brachial plexus, and nowhere near the point. So possibly yes. But having said that, I don't think there is one correct way of doing it. Number one, you will choose the block that you know to do well. If you never know costoclavicular, how will you do a costoclavicular block? So repeat the block, but be sure that already the patient is using NIV for him is night. So get the NIV and keep it there. If he develops a phrenic, put it on him. That's it. So there is a block, and you start the NIV inside the theater itself. So that's the number one. Number two, next question was.
Can I add adrenaline?
So this patient was a diabetic and hypertensive as well. And I don't really rely too much because we are not worried about the dose. So to decrease the dose, you can add adrenaline. or to increase the duration of the action. But in this particular case, being an hypertensive, I personally feel that adrenaline is not going to help so much, the pro and con. So, and also I will not use lignocaine because this is a forearm fracture. Now it depends upon the surgeon, a resident surgeon, a registrar, a consultant, senior consultant. I've seen forearm fracture getting finished either in 60 minutes, 120 minutes, 180 minutes. So lignocaine, if you use, then you have a problem because in between the surgery, the patient is going to become significantly painful. And we need to take everything into consideration when you decide what you do it in that particular scenario. That would be my answer.
Can I mix lignocaine and adrenaline?
There is no problem actually. There is a lot of, this is another important question, whether can we mix two drugs together. Lot of debate, whether only it should be only ropivacaine or only bupivacaine, or can you add lignocaine with bupivacaine. We have done everything, and lignocaine with bupivacaine has no issues. Rate of onset of the block is slightly faster, and duration of the block becomes more, because faster because of lignocaine, more because of bupivacaine. And now we have started adding adjuvant. The adjuvant of choice in my institution is dexamethasone, and 4 milligram and 8 milligram, and it prolongs the duration of surgical anesthesia. And to add on to this, even we use it in diabetic patients. There is a marginal rise of blood sugar, which comes back to normal very soon. So there is, according to me, there is no contraindication to use one dose of perineural dexamethasone in a diabetic patient, because it gives excellent quality of surgical anesthesia, prolongs the duration of analgesia. Because of this, the pain relief is adequate, because if you don't add DEXA, then the duration of the block is less. The analgesia, for example, when you use dexamethasone, can go to 16 hours to 22 hours. And in a diabetic patient, it's very important to keep the rate pressure product, which means the heart rate and the blood pressure low. So I personally feel, and my opinion is, you have to trade off between a raise in sugar and raise in heart rate. And my mind says, accept sugar level slightly high and go for an excellent analgesia, which will not increase the myocardial oxygen consumption. Because the heart rate goes high, then the diastolic time becomes less, coronary perfusion pressure gets affected, and they may have a coronary event. So my choice is to go for dexamethasone.
Yes, sir. On practical aspects, sir, in obese patients, actually, the fat is the enemy for the ultrasound anesthetist, I think. Because of the moderate, high amount of adipose tissue, most of the drug would have been deposited around the fat, thinking that it would be a cluster. Because of the high content of the adipose tissue, the upper trunk, middle trunk, and lower trunk getting splayed within the supraclavicular area. My go-to block will be the supraclavicular. I think it is the spine of the arm. That is not wrong in this case. I beg to differ with Senthil Kumar Mohan. That's what. The problem, why it is difficult, it is getting splayed because of the high content of the adipose tissue, and the paraneural tissue is not very well developed because of the so much of adipose tissue. That's what the problem here. For that, I would actually, consistently we can see easily the upper trunk. We can locate, give some drugs, make the area darker, and look for middle trunk and lower trunk. Lower trunk will be difficult because the needle will not be visible for this so much BMA of 42. So I can easily go with the upper and middle trunk and avoid the lower trunk and address it in the axillary. That could be my.
So thank you for that input, but I am like, I don't correlate BMI with adipose tissue here. BMI is a generalized fat content, and it differs from patient to patient, and it's not necessarily that there is a lot of fat deposition here. Each patient is different. So I think we need to go by the case basis, but I do take your point that obesity produces a little extra challenge, and we also spoke that, and again it's a debate whether the spinal of the upper limb is, whether it's supraclavicular or whether it's infraclavicular. There can be a separate session on pro and con. And again, I would say that if you really see, the difference between subclavian perivascular and costoclavicular is less than 1 inch. It's just the clavicle. So we needn't actually waste our time on debating where the drug has to be placed. And also it was excellently said about the chimney effect that is present because of the connective tissue along the brachial plexus. So if you place the drug in the costoclavicular, it seats up because of the chimney effect, and it actually becomes subclavian perivascular. So I think we can, and most importantly, practically, as I said, you should do a block that you are good at, whether it's supraclavicular or it's costoclavicular. Yeah.
Any ways to improve any positional changes or positional helps in achieving lower drug visibility, sir, better in obese patients?
Any shoulder loss or pulling the arm, any maneuvers which may help in better visualization, if there are any?
I think the better visualization is in our eyes, in the mind, and the ability to see it. There's no, even in obese patients, lower trunk can be seen very well, and I don't think there need be any maneuver. I think repeatedly scanning and identifying the structures, I think it's more, attending more workshops, interacting with more people, I think we can identify, and a good machine. I think machine is very important, and the probe is very important. The machine may be good, but repeated use, the probe may become bad, and the resolution can become very less. I think these are the points which I think are more important than the positioning of the patient per se. Because after some time, for example, if it's a government hospital, plenty of postgraduates are using it. The linear probe has been used several times. After some time, if you see, the image quality becomes so poor, and you don't even know which is upper trunk, which is middle trunk, which is lower trunk. All that you know is some white and black thing, and you presume and you create a possibility that the nerve could be here, and then you go. So that's why we also discussed about using the dual therapy.
I think it's because of the sterlium that they put without draping the ultrasound.
True. That's a very important point. Actually, sterlium is, many centers use sterlium to wipe between cases, but I think that's absolutely wrong. So you can actually use one cover as a protective layer, either a gloves or Sterizone, based upon whichever, and there are special covers now are available, which can be used to protect the ultrasound probe. Yeah.
Sir, I think we can finish that question also, sir. Is investing in high-end machines, getting a machine more than 20-25 lakhs is worth for patients like this, sir? In a center where we have high
investment in a good anesthetist is more important.
Yes, sir. Thank you, sir.
Point that Balankar sir emphasized is it's not about the probe. Probably I just slightly differ from his view and Dr. Prem's view. It's not about the probe, it's not about the machine. The first thing sir said is knowing the anatomy. Without knowing anything, even if you have a 50 lakhs or 1 crore machine, nothing will help you. There are a lot of machines coming in the market which has an artificial AI enabled. Even if it is AI enabled, unless until you know what you are looking at, especially what sir said is looking at the patterns. Especially with regard to lower trunk, look repeatedly for lower trunk. For each patient, you'll be able to pick up the lower trunk. Even how worse the machine is, even how the best machine is, unless your mind knows, definitely you cannot see.
No, I differ here, Sendil. The new AI machines, if you invest, it is like GPS. I get up in Courtyard Marriott and I just put Preeti Hospital, it directs you here. Same thing happens with AI. Now you say supraclavicular block, put the probe, it will say how to go. So you are not going to miss it. You need not know the sonoanatomy at all. The new machines, and actually it is going to guide you. And the nerve will be encircled in yellow color, and the artery will be in red colors, and it will show you exactly where it is. So the new machines, when you invest, you even know where it is without even knowing sonoanatomy. But I'm not saying that that are the ultimate areas, but your ability to visualize sonoanatomy is truly crucial. But investing more will not go as a waste. It's a GPS incorporated inside. There are few machines which are available which says go left, go right, go deep, go half centimeter deep. It has integrated the AI inside. So when those machines come, then this block failure will never happen. No. Actually, what I'm trying to tell is technological advancements, when it is incorporated, becomes a great tool for the beginners. And the concerns will become less, the block failures will become less.
Yes, sir. Like GE's Venue machine has a SonoNav software. Like it is very good for beginners. If you keep the machine there on the right side, the sono anatomy just comes on the right side. So you can just see that, optimize your image, optimize the structures which you want. So definitely it is a boon for beginners and teaching institutions.
True. Yeah.
Yes. Can we move on to
Yeah,
the
yeah,
next
next question, yes.
Sir, is there any questions or doubts which can be asked to the panel experts? Okay, sir. We will
But I go by Dr. Sendal, sir, so every day. Suppose tomorrow you have to do 2 upper limb blocks. Please visit. Now you have the library in hand. Please see the videos. Keep on seeing the structures. Every time you see the structure, every time, then you know you have created the mental creation. And when you put the probe, immediately you will be able to identify the structures. So keep on seeing the videos, and then things will become easy. And whenever you give general anesthesia for an abdominal surgery, and if the ultrasound machine is there, when you put the patient to sleep and intubated, use the ultrasound probe to scan and keep on seeing it, so that there is a lot of coordination between your eyes and the sonoanatomy that you are visualizing. Yeah. Next.
Thank you very much, sir. Going on to the next case scenario. This is again a 65-year-old male came for a distal humerus fracture. He is a known diabetic, systemic hypertension on regular drugs. He is a known smoker with chronic obstructive pulmonary disease, and his echo shows left ventricular hypertrophy with mild LV systolic dysfunction and mild pulmonary hypertension. The patient is posted for an open reduction internal fixation with plating for distal humerus fracture, posterior approach. This means the patient will be in lateral position during the surgery. Written consent explaining the high risk for anesthesia was obtained, and plan of anesthesia was an ultrasound guided intrascreen block with around a 10 ml of 0.5% bupivacaine. The post block 15 minutes, within 15 minutes patient completely relieved of pain. He was comfortable during positioning. Even during the pre-wash, the patient was comfortable, draped, suturing of the draping done without any pain. But on incision, patient complained of pain. So I request Dr. Narasimhan sir and Rajaram sir to guide us how to proceed further.
Yeah, I think that this is a very classical scenario, and I think if you are the beginner, if you have a distal humerus fracture, posterior approach, you need to be really careful, because patient after the block is gone into the lateral position, fully painted and draped. So this case is very, very important, and the safety is very important. What you are going to do is very important. So this is a very, very interesting case, and we have gone through this real-time scenario. And I think, Dr. Narasimhan, can you take us through this journey of why this happens and how to prevent this? It's a very nice case.
Thank you, sir. As we were taught in Ganga Hospital, sir, I'd like to see 3 things. What is for any surgery, leave alone this surgery, I'd like to see what dermatomes the incision is going to come. First thing, what myotomes, what muscle the surgeon is going to reflect, and what osteotome or bone which the patient is having pain. Probably, so this is for a interscalene block. So this is the first diagram is the osteotomal distribution. Second one is the myotome, and third one is the osteotomal distribution. In this case, they have used 10 ml of 0.5% bupivacaine. So on C5 and C6. So probably it would have taken care of the osteotomal pain. So while the pre-wash and during draping, patient had good pain relief. But what could have been missed is checking the dermatomal part. So as you can see in the diagram, the medial part is supplied by intercostobrachial and medial cutaneous nerve of the arm. Also, posterior cutaneous nerve of arm receives communications from intercostobrachial nerve. So, with the interscalene block with 10 ml, it could have probably acted C5, C6 and probably C7 level. So, the lower trunk, C8 and T1 might have been spared. As we can see in the next diagram, in the dorsal aspect, the posterior cutaneous nerve of arm and forearm is from C5 to T1. Also, medial cutaneous nerve of arm is C8, T1, and we have intercostobrachial nerve. So probably what could have happened is missed dermatomal levels because of sparing of C8 and T1. So that could be the possible cause of dermatomal pain.
Okay. So I think first question I want to ask the audience. Looking at the case scenario, patient is a known case of COPD, smoker. Was it the right choice to go for an interscalene block in this patient for a distal humerus fracture? Yes, no? How many of you say no? Please raise your hands. Excellent. I think the objective is achieved. Why no? Phrenic involvement. So, first and foremost, for a distal humerus fracture in a COPD patient, we possibly need not have gone for an interscalene block. That's number one. That's a take-home message. And you would have possibly gone for an infraclavicular approach to brachial plexus in a COPD patient, which will give adequate surgical anesthesia for a distal humerus fracture. And Dr. Narasimhan beautifully narrated that patient did not have any pain on movement. That was because osteotome and myotome were taken care by the block, even though they did an interscalene. But the problem was dermatome. So a take-home message for everybody, next time when you see a distal humerus fracture, approach is posterior, in posterior approach, and patient is in the lateral position. This is how all the distal humerus fractures are fixed. Now, that was an excellent explanation about the communication between the intercostobrachial, and the intercostobrachial has got its root value from T2. So when you do an interscalene block, you don't block T2. So that's one reason. The second reason, which is thought to be, is the posterocutaneous nerve of the arm also gets twigs. It's called prefixed brachial plexus. So you may get twigs from C3, C4. It's a prefixed brachial plexus. So when the brachial plexus get twigs from superior, it's called prefixed. When it gets from inferior, it's called postfixed. So it could be a prefixed brachial plexus, so which can result in this. So in all our cases, it's a dictum. Whatever method you choose, whether you give costoclavicular, whether you give infraclavicular, or if it was not a COPD, you give a subclavian perivascular, or even if you did an interscalene, as a dictum, we always infiltrate the dermatome after the patient is positioned. So the problem is the incision site. So we put a T-shaped infiltration. We divide the arm from the upper arm to lower arm at the level of the middle 2/3 and the lower 1/3. Horizontally we infiltrate and vertically we infiltrate. So the dermatome where the incision is going to be made, we additionally give local anesthetic infiltration to take care of dermatome supply. So this is done prophylactically to prevent the possibility, because there is no way to find out whether the posterocutaneous nerve arm is prefixed in this particular case. No way we know that whether intercostobrachial is giving a twig. So to make it sure that dermatome is blocked, you always do local anesthetic infiltration after doing your brachial plexus. That's number one. For all the youngsters who are embarking on the journey of getting into regional anesthesia, at least in the first 1 and 2 years, if you are in private practice, if you get a distal humerus fracture, lateral position posterior approach, I strongly recommend please give general anesthesia along with the block. Because it's a nightmare that completely draped, you can't even go and keep a mask there, and if the patient has just pain alone, it is okay, but many times they go in, because of the pain, they go in for severe laryngospasm, and then it becomes a huge problem. Now it's all trapped, and then it takes time, and now surgeon has opened it, it's become unsterile, and it makes a human cry until you reach a stage which you are extremely good in intubating laterally or having a supraglottic device which you can insert. You can protect the airway. I strongly recommend for the beginners, when you have a distal humerus fracture, give GA and then do the block until that day when you have tremendous confidence with your surgeon and tremendous confidence in your airway management capabilities. This is the take home that I wanted to share on a distal humerus fracture. Open to the panelists for more thoughts.
So one important point, sir, as you said, even before you put the patient in lateral position, after giving a block, ensure, like what Dr. Narasimhan said, to probably discuss with the surgeon the line of incision, check for the sensory level along the line of the incision, then position the patient. For not alone distal humerus, for any surgery, ensure your block has taken up 100%. Then you do ask the surgeon to do things. Probably that will be much better, so that you can have a rescue blocks or the second plan B to work out even before the patient has been draped and positioned.
I just take a
yes, please.
Small alternate view on this point, patient, sir. I would like to go ahead with the same interscalene or supraclavicular, whatever it is. And if we are a senior consultant and we have a very friendly surgeon, for this same patient with so much comorbids, if the surgeon's consent is not about nerve exploration, I would suggest him if he can go for the anterior approach with a MIPO technique. So
no, we should not throw challenges to the surgeons. Not considered to be very good. As long as Prem gave a lot of adjectives, but elbow fixation, a distal humerus fixation, final outcome is superior in the posterior approach with less vascular thing than a anterior approach. And eventually, the patient surgical outcome has to be good and his limb has to be functional. It should be a good fixation. And also, if you take even a senior surgeon...
This is only discussions.
No, I completely agree with you. But even the senior most surgeons, if they have not been exposed to an anterior approach of distal humerus fixation, I don't think we should suggest. This is my opinion. Nerve injury is more actually, yes. Yeah. And also I think as anesthesiologists, when we don't want them to infringe into our territory, I don't think we should infringe into their territory on saying, go for anterior approach. So because Prem, we shouldn't give bad ideas.
Yes. No, that's why I said it's an
He's the
alternative.
HOD now of Mehta Hospital, so now he's okay, he can speak. But I don't think everybody can speak this.
Because the orthopedic surgeon, head is a close friend of mine. Sometimes we have a
So
discussion.
he has decided to make him his enemy. The close friend, he has decided to make him an enemy. 3 times he challenges him like this, then possibly he will post a case when Dr. Prem is on leave. Or he will never post a case of an elbow case when Dr. Prem is around.
So when multiple comorbids is there, we have put a point to the surgeon saying, cement might be a problem in certain patients. Say for example, they wanted to do a hemi. So in those patients, they have put modular hemiarthroplasties rather than cemented.
No, this point is agreed. So this is a valid point. You are saying cement can produce a drop in systemic vascular resistance, can produce myocardial depression. So in this particular case, because geriatric patient, multiple comorbidities, please avoid cement. That is fine. That is physiological changes that can happen in the internal milieu, they will agree. But the previous one, you are challenging their surgical capabilities. So that is not accepted, but this one is accepted. And here in this case, chronic smoker and COPD, I don't think it's a challenge even to give general anesthesia. We have reached a stage where you can do lung transplantation. So this is just not something we need to really worry about. I don't think the capabilities of the anesthetist have increased so much that they should become well versed in anesthetizing even the sickest patient with keeping targets and goals in mind. And I think never should we consider somebody unfit to give general anesthesia. And we need to devise technique and strategies to do even sick patients under general anesthesia and come out of it. The simplest way of doing it is, for example, if it's a COPD, is a smoker, it's a hyperreactive airway. So you will avoid all histamine-releasing drug. You will choose rocuronium, a steroid-based rather than atracurium. So everywhere you will try to tailor make. You will use Sugamadex reversal, so you will use rocuronium, use the Sugamadex reversal to get the reversal back to normal. So it's just that our approach, our strategy that we need to incorporate, and I don't think we have reached a stage where we can say that we can give anesthesia to whatever be the medical illness, will be fit to do, because anesthesiologist has evolved to give anesthesia to end-stage liver disease, end-stage heart disease, end-stage renal disease, end-stage intestinal disorders. Now we are going for intestinal transplantation. So in this era of complete organ dysfunction, an anesthetist is capable of giving anesthesia. These are all nothing. So this also, I just want to drive home the point that we shouldn't, patient safety is important. Yeah. Yes, sir. Well, whatever sir says, I'll agree, because he's the secretary of ISA Madurai City branch.
Sir, can we do it in even supraclavicular or costoclavicular? Because it's just distal humerus. Only problem is the lateral position. Even I have done a lot of cases under the supraclavicular itself. But being the patient is a high-risk patient with all the respiratory problems, if you consider the phrenic nerve, even in the supraclavicular, shall we go for the costoclavicular?
100%, sir. No, definitely yes, because costoclavicular is a good solution for this, provided you know how to do costoclavicular block. Yeah. So tomorrow's workshop, we need to really teach them the costoclavicular approach to brachial plexus, because many of them have not done it. Definitely yes, sir. Yeah, it's a good approach. Yes, sir.
Costoclavicular, we have to abduct the arm. It may not be possible with the humerus, or it will be very difficult.
Yeah, you are right. Sometimes you will not be able to see costoclavicular without abduction. And in that case, then possibly you need to consider two things, like maybe a very small volume supraclavicular, so that the phrenic, so then little bit analgesia, then you can go for costoclavicular. That you can, over a period of time, you can handle it, or a little dose of fentanyl, and then an abduction. But the point is very well taken, because costoclavicular is an abduction of the arm.
Sir, now you have mentioned we can give a block in the same patient at two various levels. Can a patient with a forearm fracture, patient will be on tourniquet. So if we need, can we give a volume of 10 ml in supraclavicular? Then if I am not able to see the lower trunk, can I go for a axillary block? Give another 10 or 15 ml there.
Absolutely fine. This is being practiced in many centers. A combination of the blocks. You didn't see it well there, and you used a supraclavicular approach because you want the shoulder to be completely relaxed. But you didn't see the lower trunk, so you're going to come and do it in the axillary. Absolutely fine. Yes. Like doing a mix, but primarily all the dermatomyotome osteotome should have been covered.
No block along the axillary sheath, its problem has came down to almost like Niels.
No, sorry, I didn't get.
After I am, for particular case, I have done a supraclavicular block, and routinely I am doing intercostal brachial nerve block at the axillary level, and also medial cutis nerve. So most of the time it is not working fine. But the problem is locating the intercostal brachial nerve. That may be possible to visualize it in 50%. Even though it is not visualized, we can give a 7 to 10 ml along the axial sheath. It usually works well. This posterior pain along the insertion is not happening to me. It was happening earlier.
So the other option is also to go for the supraaxillary approach to brachial plexus. Scan the in the axilla above. Look the bunch of grapes in the supraaxillary region, which has got the medial cutaneous nerve, intercostal brachial nerve. So you can block it there also, sir. So where it's a definitive block.
Yes.
Yeah.
Yes.
So tomorrow in the workstation, please ask for. All of you know axillary approach. There is something called supraaxillary block. So please learn the supraaxillary block in the workshop tomorrow, and once you put there the drug, the intercostal brachial also will get blocked.
Both of these cases may look terrifying, sir. The preoperative patients' comorbidities like OSA with a home BiPAP therapy, a COPD patient. But we want a take-home message that these patients can easily be managed under GA
just don't be terrified with the comorbidities, because a OSA patient with home BiPAP therapy, how we can go a pre-oxygenation, how we can go for a GA, but these patients are already in BiPAP, so we can very well, patient will be comfortable in BiPAP, so very well we can proceed post-op NIV also. The attendants will also accept that, sir. So I want these two cases, I want a message that these cases can be done under GA if a block fails.
Absolutely, yes. That's what I said. There is no contraindication for GA.
So rightly those message has been transferred, I think, sir. Thank you very much, sir. Sir, any questions from audience? We can, otherwise we can proceed to next case. Because these two cases will be happen day to day in every hospitals, in every scenarios. So any questions or any doubt, if you face any scenarios like this, you can put forth the questions so we can get the opinion from our experts.
No, but one take home, as I told, for the youngsters who are going to enter into private practice, not in a corporate setup, where you don't have great support, when you are alone, when you embark on a journey of doing all this, anything that is not supine, in the first few years of your practice, anything that is not supine, don't do it only under a block. If it's a lateral position or if it's a semi-sitting position, please add general anesthesia, protect the airway, and then do the block also for pain relief, for the safety of the patient. That's number one. Number two, I also wanted to share a recent history of a 52-year-old male, bilateral shoulder surgery, single sitting, and this patient had bilateral block plus GA. And why I wanted to just mention is this is not a complication of regional, but a complication of the position. 6-hour surgery. He was the CEO of a big institution. He said, I want to undergo both the surgeries because I don't get leave. I've got only 4 days leave, so do both the shoulders at the same time. 6-hour surgery. And after extubation, do you know what complication he had? So one was CVA, one is bilateral phrenic, positional brachial plexus, blindness. Actually, he became blind. He became completely blind. Even today, he is not recovered. Reason was, I spoke to the anesthetist because this patient was known to one of our surgeons. So this was done in one of the very popular hospital in Gujarat. And the problem was both the hands painted and draped. And the anesthetist put the cuff sitting position. Anesthetist put the BP cuff in the cough muscle. And he was checking the blood pressure and treating the patient according to that BP. And the BP, what it reflects and the perfusion of the cerebrum was completely different. So he had produced 6 hours of complete hyperperfusion and retina supply was, and he became blind. Even today he is blind. So one important take-home message, if you decide to do a bilateral shoulder, number one, most of the surgeons don't do it. But if you do it, tell them that you will monitor in one hand. So ideally, the tragus is the where you will actually see. If they insist on that, then you have to use an intraarterial line. You have to do an NIP, invasive blood pressure monitoring, and it should be adjusted, the zeroing should be adjusted to the tragus, so that the perfusion pressure of the central nervous system is continuously maintained in a sitting position. This is just another take-home message which I wanted to give. Yeah, thank you. We'll go to the next case.
Yes, sir, we can proceed to next case, sir. So next one is a 55-year-old male, again a chronic smoker post-tuberculosis sequelae with COPD, has undergone an interscalene block for clavicle fracture. Again, the interscalene block. Developed respiratory distress followed by a desaturation, and he was not able to lie down after 5 minutes after the block. So I request Velmurugan sir to guide us through this difficult scenario.
So, being a chronic smoker and post-tuberculosis sequelae with COPD, actually we should not have chosen the interscalene block first. So that is the first take-home message. Number two, the reason for the respiratory distress is obvious. So if you go for intercranial block, so naturally 70 to 100%, even with your ultrasound, more than 70 to 100%, definitely your phrenic nerve may get blocked. Okay, so number two, it's a rare chance, even with the intercranial, chance for pneumothorax may be there. If you are advancing needle inadvertently, because even some of the novice technician, if you are using this ultrasound, if you don't know where the needle tip is exactly, you can see the shaft as the tip and you can miss the tip, it may go even into the deeper planes. And definitely these COPD patients definitely have the emphysematous chest or something else, so definitely the pleura will be a little bit higher level, so naturally chance of your pneumothorax may be there, but a little bit rare disease. So obviously there are two causes may be there, one is phrenic nerve palsy, number two is your pneumothorax. So if it's so, then you have to immediately you can go and you can diagnose it also. So if you are having an ultrasound, you are doing a block, so naturally you can go and see the diaphragmatic movement. So if you check the diaphragmatic movement with your ultrasound, with your M mode, then naturally you can see the diaphragmatic extension and you can come to the conclusion that it is only due to the phrenic nerve block. Okay. Or otherwise, even in the B mode, if you are going in the intercostal space, you are going to see your comatale artifacts, comatale signs and other sliding sign, then your lung is intact. If it is disappeared, the patient has the pneumothorax. So by this having an ultrasound with you, you can rule out both the causes, the phrenic nerve palsy as well as the pneumothorax. And if you rule out that, then you can manage accordingly. And the next question is, the patient is not able to lie down also. So how will you manage? Anybody else from the audience? So now the block has taken well, but the patient is going for respiratory distress, but the patient not able to lie down. How will you proceed now?
So one question, why do you think the patient was not able to lie down?
Because this patient definitely having the respiratory reserve will be decreased, because having a smoker, COPD and post-TB sequelae. And if you are going for an intercranial block, then actually more than 70% of patients have the phrenic nerve block. So if you are going to block the phrenic nerve, your vital capacity will be decreased around more than 25%. So if you are having a borderline reserve capacity with a decrease in the vital capacity of more than 25%, naturally the patient may go for a respiratory distress.
No, I agree with the respiratory distress, but the only point is probably is becoming more dyspneic on lying down. So I think the solution is having it, the clinical scenario, if it has happened, the best thing is to go for NIV. All that we can come out of this, still continue the case and just do it under NIV, because that will increase the vital capacity. So what exactly is your solution for this case, sir?
Yes, sir. As you said, you can go for NIV, even if the patient is not adapting to that. If it is not able to lie down.
You can, instead of going in for complete supine, we can go for about 30 degrees
semi-reclined position.
So the diaphragm is at a better advantage to move, and then put on an NIV. Yeah.
If it is not possible, then at the last resort you can go for a GA with LMA, sir. If you having a COPD and post-TB sequelae, you can even go for a LMA. That will be ideal in this situation, sir. Because this is a clavicle fracture, so there will be any change in the position also, so easy to manage also.
So, sir, now for discussion's sake, what would have been an ideal block for this patient?
Yes, sir. So the first choice maybe you can go for a clavipetal fascia block.
Absolutely, yes. Yeah.
So that is I think recently, even with or without comorbidity, I am always choosing a superficial cervical rectus block along with a clavipetal fascia block. That may be absolutely easy to maintain a clavicle fracture.
So that's a very important take-home message which I wanted to give. Next time you see a clavicle fracture, most of the clavicle fracture are managed conservatively. But some surgeons feel that you need to plate the clavicle. The next thing you need to know is where there is a fracture. Clavicle fractures are always between the junction of the medial 2/3 with the lateral 1/3. That is the where it gets broken or it broken. So number one, identify where the fracture is. Number two, as Sir said, clavipectoral fascia block. It's a new described block, and probably tomorrow you will be during the scanning session you will see that. The point is very simple. There is a fascia that covers the clavicle. All the nerve endings pierce the fascia and supply the bone. So all that you need to do is you can do this block even without ultrasound, ideally. You need to go and hit the clavicle on either side of the fracture and deposit your local anesthetic solution. So it is going to block all the nerve endings which are piercing the clavipectoral fascia block and completely anesthetizing the region. But as Sir said, the most important thing is the osteotome is taken care of, but the dermatome is not taken care of, and that's why you have to block the supraclavicular nerve also along with the clavipectoral fascia block. And tomorrow in the workshop, you'll identify how to block the supraclavicular nerves. And for those who don't have an ultrasound now, and you want to do a clavicle fracture, simple thing is palpate the fracture, hit the clavicle bone on either side, inject about 6 to 8 ml of the drug on either side, and if you turn the patient's head, you see the sternocleidomastoid, you see the extrajugular vein crossing the lateral border of the sternocleidomastoid. Just above that, just above where the extrajugular crosses the lateral border of the sternocleidomastoid is where the supraclavicular nerve comes and turns and comes. So you insert your needle, skin subcutaneous tissue, about 3 to 4 ml, the supraclavicular is blocked, and you block the clavipectoral fascia. It's an excellent block for clavicle fixation. Now, next important thing which I wanted to share with you is this patient was given an interscalene approach to brachial plexus. Patient has got a clavicle fracture. So I will give one real-time case scenario which we had. So this patient, polytrauma, had multiple injuries in the lower limb. So in fact, he had a neck of femur, shaft femur, supracondylar femur, tibial condyle, tibia fracture, ankle fracture. Everything fixed under combined spinal epidural, 6.5 hours duration, everything was done. And when everything got over, the surgeon said he has also got a metacarpal fracture which needs. So now we went and did this was long back when the ultrasound was not there. I think it was way back in 2006. So we used a nerve stimulator to do the block, interscalene, and just 2 ml drug was given and got the correct stimulus. 2 ml was given and patient became apneic, bradycardia started, desaturation started. So what could be the reason? Only 2 ml. Excellent. So why 2 ml interscalene? Why should it enter the interscalene space? I mean, why should it enter to produce the high spinal was the next question. So this is the next take-home message. Even we didn't know why it happened. Then searched the literature. And then after that, we did an MRI to the patient. So this is another take-home message. Whenever there is a clavicle fracture, also there is an injury to the covering of the brachial plexus and the brachial plexus injury. Even if the brachial plexus is intact, there is a disruption of the connective tissue of the brachial plexus. So the 2 ml that get in seeps inside to produce a high spinal. And we did an MRI later to find out that the soft tissues covering were all disrupted. So like a capillary action, you just gave 2 ml, it seeped and produced a high spinal. He was revived. So the take-home message is, whenever you do a clavicle fracture and you decide to go for an interscalene block, important to know about the phrenic nerve palsy, but also it is important to know that there could be a disruption of the covering of the brachial plexus, and you can produce a high spinal and an apnea for a different reason. So this is another point which I just wanted to share with all of you. Yes, sir.
What could be the maximum volume that you can give an enterscalene, sir? Even with the fascia also, we know that it can still go through the cervical epidural space. Like, what do you recommend? Like, this you should not exceed this much amount of volume.
So now we have gone to an era of safety, and with the advent of ultrasound, I think about 10 to 12 ml of drug is absolutely sufficient to give an extremely good quality of interscalene brachial plexus block. But when you don't have an ultrasound, when you use a peripheral nerve stimulator, you increase it up to 15 to 20 ml, still it is considered extremely safe. But having said that, in every case of interscalene block, always expect hemidiaphragmatic palsy and sometimes the possibility of a high spinal.
One more suggestion is better to target around the C7 rather than going for C5 at the higher level. Even if you are going, as you said, even 12 ml, even it may go and block over the phrenic nerve, which is placed just over the scalenus anterior. If you are going around the C7, it will be safer, I think, sir.
So now it's the era of splenic nerve sparing blocks. Plenty of blocks have been described now. One is the low volume interscalene. Other one is the SCUT block, where you selectively block the upper trunk block. Then you go for anterior suprascapular with axillary block. Then you can target the C7 and give. There are 8 different blocks that have been identified to produce shoulder anesthesia and analgesia without producing a phrenic involvement. And also, having said that, in an ASA grade 1 patient, a phrenic nerve involvement does not produce clinically any issues. This is only in patients with respiratory compromise and COPD. Otherwise, unilateral phrenic nerve involvement in a healthy adult male is of no problem. And I think we needn't worry about it, but we need to know that in respiratory compromise, then you need to be careful.
I think we can move on to next case. This is a young adult, ASA1, has undergone interscalene block for shoulder arthroscopic surgery. Immediately after block, he developed hypotension, arrhythmias and cardiac arrest. And I request Dr. Rajesh sir to help us in tiding over the situation.
This is a real nightmare scenario because ASA one patient who had been posted for shoulder arthroscopy and interscalene approach of brachial plexus is a well accepted way of giving anesthesia for this patient. But unfortunately, the patient had developed hypotension, arrhythmias, and followed by cardiac arrest. So, according to me, the cause, if you search for literatures related to this, the first and foremost cause which has been put up is the Bizard-Saris reflex, that is post-interscalene brachial plexus block. That happens because of venous pooling, because of the vasodilatation and venous pooling and keeping the patient in the B chair position for shoulder arthroscopy, where there will be reduction in the preload and the left ventricle is empty and it is pumping fast against strain, producing arrhythmias, and the patient can land up in cardiac arrest. That is the one thing which has been given. But there are other causes which we have to think about, like as Dr. Balavenkat sir has mentioned about the neuraxial spread following an interscalene brachial plexus block. So the dural sleeve, if you puncture the dural sleeve and give a small amount of local anesthetic, it can move into the spinal space and it can go into the it can go intrathecally and can produce a picture of total spinal. It can land up with cardiac arrest. And one more thing is that neck area is highly vascular. So if you are not alert with switching on your Doppler and visualizing all the vessels, what is there inside. So if you inject a large volume, without monitoring all those things, there is a possibility that this patient can land up with local anesthetic systemic toxicity very fast because of the rapid intravascular injection, not from the systemic absorption, rapid intravascular injection per se. So during the injection per se, patient can go in for cardiac arrest. So one such reason is the possible thing which has happened for this patient. That's what I feel. And if you look at this picture, see, there are plenty of neck vessels which are there around. So it's a mandatory thing to look into the ultrasound with color flow Doppler before putting your needle in. And very important vessel is your vertebral artery. So we think that the vertebral artery is not seen the moment you go up to the level of C6. It is present. It is not seen. The tubercle is obstructing the view of vertebral artery. But the vertebral artery is there till it goes to the brain. So if your needle can go through the gap between the two tubercles, there is always a possibility that you can inject intravascular and you can get this catastrophic. And there are a lot of periradical arteries also there. And those can supply the spinal cord. So those arteries, if they get injured, also the patient can land up with spinal ischemia and related problems.
So I think one of the surprising thing is this directly went into, if we consider it as local anesthetic systemic toxicity, it directly went into cardiac symptom without giving warning of any neurological symptom. So normally you also have an associated convulsion that is usually present initially, followed by an arrhythmia, a cardiac arrest. But here it's been direct, but it can happen. So literature says that without neurologically, directly it could be cardiac as well. So now I think, sir, what do you think is the difference in handling this patient versus any other cardiac arrest?
Sir, the total scenario from, according to that ACLS guidelines, that the total scenario of reviving a cardiac arrest from other conditions, and this is totally different because this cardiac arrest revival depends upon one drug, that is intralipid. So it becomes mandatory to use 20% intralipid as early as possible. The moment you recognize that the patient is developing local anesthetic systemic toxicity, even if there is an intrathecal spread also, there are a lot of evidences that where we can use intralipid to reverse the condition. So I think it should be mandatory for each and everyone, those who are practicing regional anesthesia, to have intralipid along with them to resuscitate in this scenario.
So I think as we start regular resuscitation, primarily we'll go for airway breathing circulation like any other cardiac arrest. But as Sir said, I think it is truly important to also start this patient on intralipid. And how many of you here in the institutions that you work have intralipid with you? Please raise your hands. I think a lot of centers do not have intralipid. So I think it's very crucial and important when you get back to work on Monday. It's not very expensive. So every institution practicing regional anesthesia using so much of local anesthetic solution should have 20% intralipid inside the operating room, and it has to be used. And I think this is a mandatory, and this is a dictum in patient safety. And another important thing is not only having intralipid, every anesthesiologist should know where it is kept. Because many times it's only the technician who knows where the intralipid is. And when a convulsion happens, it's practical for you to know where this intralipid is kept. So I think one, to procure it. Second is to know where it is kept and how to access it 24 hours. Yeah, I think that was an important case scenario. Yeah.
Any comments from other panel members also?
Whenever an interscreen is given, once we see the nerve, we tend to go ahead with the block. It is always good to initiate a Doppler at that point because there is always a transverse cervical artery which goes near the interscreen region. So always it's better that we see a Doppler before giving the block.
So that's a very important point which Dr. Prem is mentioning. This is just not for this block, for every block. This is called the SCOUT scan. once you have identified the sonoanatomy, and before you insert the needle, you initiate the color Doppler, see if there are any pulsating vessels, and when you initiate the color Doppler, the pressure that you apply on the patient's skin also has to be slightly relaxed, because if it's a vein, it opens up. The arteries will pulsate, but the veins will get compressed if you put a lot of pressure. And when you insert the needle, what happens is the veins open up because the pressure is not maintained by your hand. And what you didn't see earlier, we can still end in a catastrophe. So when you do the SCOUT scan, the pressure that you exert has to be slightly relaxed. See if there are any veins and arteries before you insert the needle. I think that's a very, very important point.
And one more point which I want to add here is that after placing the needle correctly, if you are able to visualize the needle tip, but you are not able to visualize the drug, that means the drug is going intravascular.
Yes,
so
that's another very important point. So when you inject the drug, you should see the anechoic spread of the drug. And when you don't see the anechoic spread, that means that either you are not in the target or it is going intravascular.
And one more thing regarding the interscalene blocks, even a negative aspirate doesn't ensure that you are injecting intravascularly, because when you aspirate, the needle little bit comes outside. But when you try to inject, it can go even 2 or 3 millimeter deep. Behind it, it can be even the vertebral artery. Just 2 ml of local anesthetic directly into the vertebral artery can produce neurotoxicity and seizures, and may displace the needle further, and further injection will end up in catastrophes.
So primarily, it's small aliquots that are given, and always the tip of the needle to be seen. And the first injection, you should see an anechoic spread of the drug. All this makes it extremely safe.
Thank you, sir.
Regional anesthesia is not as complicated as what it is today, because we are talking about all complications, and we are really scared. Like people now will interscalene போடணுமா இவ்வளோ கேட்டதுக்கு அப்புறம் interscalene போடணுமா நான் regional anesthesiaவே கொடுக்கல நான். But we are trying to talk about all the complications so that no patient suffers from these complications. That's it. Because otherwise, this whole workshop is to promote regional anesthesia. But you should not go back thinking that பேசாம ஜிஏ கொடுத்து டியூப் போட்டு டியூப் எடுத்துட்டு விட்டுட்டு போகலாம், பேஷண்ட்டுக்கு வலி இருந்தா என்ன வலி இல்லைன்னா என்ன, பிளாக் எடுத்துச்சா எடுக்கலையா. This conference will defeat its purpose. This is just to make sure that you don't have any issues with your regional blocks, but definitely this is not as complicated as we all project it to be. So don't get worried about this discussion. Yeah.
This is a 25-year-old female who developed hoarseness of voice and lacrimal congestion after an interscalene block. So with this scenario, we can, like after an interscalene block, there can be 2 or 3 options. Number one option can be like, especially after an interscalene block, is where the drug can seep through the facial planes and end up with drug going into the cervical sympathetic chain, causing an Horner's syndrome. Or sometime even if the drug can seep posteriorly, it can even go to the recurrent laryngeal nerve and cause hoarseness. But if you see this scenario, there is lacrimal congestion and hoarseness of voice. So considering these 2 scenarios, we can come to a conclusion that this can be probably Horner's syndrome, because there are 4 components of Horner's syndrome, as you know. PALM, you can remember the mnemonic PALM: ptosis, anhidrosis, lacrimal congestion, and myiasis. So considering these 2, we can say it is probably Horner's syndrome. So one common misconception when people start doing regional anesthesia, especially regional nerve block, is as soon as they keep the ultrasound machine, they immediately go and see the nerves. So they take the needle, target the nerves. But that's not the ideal way to go. You always do a SCOUT scan. You always scan the structures. You can see the nerve, you can track the nerve, but always scan the structures around it. So when you see that, you will find a lot of abnormalities. So you will find a lot of abnormalities. Have a plan in your mind. see some you might find a lot of anomalies when you do that. So when you when you do a scopes scan of all the structures, you might end up with finding a lot of new scenarios. Say example, you might find a cervical rib, you might find cervical nerve roots coming from the anterior scalene muscle. Who knows? Like, so such things should be always be bear in mind. So in this patient, the one point which I would like to tell the audience is, always whenever you do an interscalene block, always prefer doing a lower volume block, as Sir said. Sir was suggesting about 10 to 12 ml. So always give a low volume block, and you always know that interscalene has a very thin connective tissue. So always go for a low concentration, and always be always be careful about your injection pressure. If you have a machine like B-Smart or Turen, you can always see what is the injection pressure you're giving, because the larger your injection pressure, it might easily seep into the facial planes and through the prevertebral fascia, and it can go to the stellate ganglion. You can see that if you see the image, you can easily see the stellate ganglion there. So you can see below the carotid artery, you see a longus colli muscle. Between the carotid artery and the longus colli muscle, you see a hyperechoic dot. That's the stellate ganglion. That's the inferior C8 and T1. That's the sympathetic ganglion coming from the carrying the cervical sympathetic chain. And one more thing is the recurrent laryngeal nerve, which usually comes in the tracheoesophageal groove. And can you show that picture also? So that's yes. If you scan it at the cricoid region, and if you know airway ultrasound of POCUS, you can easily find out that cricoid cartilage is like an inverted C. So when you see the structure, you see the thyroid also there. To the right and left, either side you will see the esophagus. On the exact tracheoesophageal groove, you can see a hyperechoic white dot. But if you put a Doppler, you will find the inferior thyroid artery going there. So just on the tracheoesophageal groove, you will find the recurrent laryngeal nerve. So this is how you have to identify stellate ganglion and recurrent laryngeal nerve.
So I think this case was probably discussed to say that this is a side effect of the block and definitely not a complication. It is not producing any morbidity except for some discomfort to the patient. In fact, when we were using the blind technique, the block success was directly related to Horner syndrome. If you get Horner syndrome, then your block will work. So that was what I was taught when I was a postgraduate. So it is a side effect of the block and not a complication. And it is not going to produce any issues except for hoarseness for some time. And even if you are a singer, you don't worry, because recurrent laryngeal nerve will recover. And within 24 hours, you will get back the same voice. But probably the case scenario was put in to show why this happens, to be aware of and to explain to the patient and to reassure the patient that everything will be good in the next 24 hours, but no morbidity.
I had an experience, sir.
Yes, sir.
This was happened at least 7 or 8 years ago. I took a shoulder arthroscopy case, as usual, an interscalene block along with GA. So I think I would have given, at that time, I would have given more volume of interscalene block, almost 15 to 20 ml I would have given. And intraoperatively everything went on well. And after the surgery, almost 1.5 to 2 hours after that, post-extubation, the patient went for a laryngospasm. Is there any relationship with the increased volume of the interscalene block along with the recurrent laryngeal nerve residual effect? Is there any chance for aggravating this or initiating this laryngospasm post-extubation, sir?
Sir, I don't really think that this has got a direct relationship with laryngospasm. Laryngospasm means it is an involvement of both the cords. And when we give an unilateral block, it is going to recurrent laryngeal nerve. It's a unilateral vocal cord that would have got affected and not bilateral. So I think here the cause of laryngospasm is like any other laryngospasm which will happen after a general anesthetic. And I don't think the block has aggravated the laryngospasm. This is my thought. Yeah.
And moreover, the efferent arc of laryngospasm is the recurrent laryngeal nerve. If it is blocked, the laryngospasm could not occur.
Yeah, and also it's both.
Both sides.
Both sides.
Both the recurrent laryngeal nerve actually goes, both the cords will be abducted actually, more than adduction.
Yeah.
Yes, sir. So, and one more point is, if we, not only about regional anesthesia, if we inflate the endotracheal tube cuff beyond a limit, even that can produce recurrent laryngeal nerve palsy. So we have to keep that also in mind.
So now actually there are a lot of gadgets which are available in commercial market which are very cheap. Now there is a syringe, the new company is just a syringe for cuff pressure monitoring for long procedures. I think you can repeatedly measure the cuff pressure, the endotracheal tube cuff pressure, and minimize the possible the cuff pressure and producing submucosal ischemia to the subglottic region. So there is a lot of advancement which has made anesthesia more safe and to give the best to our surgical patients when they are ready to spend. I think we need to be ready to use the modern technology to understand what it can do and offer the best to our patients.
So this is again a young male patient, post-op distal and fracture fixation under axillary block. Patient complaint of paresthesia during drug injection while they are giving the block. Now patient presents with a wrist drop on post-operative day 1. I request Rajaram sir to help us in understanding the situation.
Again, it's an unfortunate incident, but in general, I would say proximal blocks have higher risk of peripheral injury rather than the axial block, but I would not say that it should not happen because there is a paresthesia here. There will be difficulty in locating the radial nerve. That would be a problem because hyperechoic enhancement behind the axial artery would have been misled as a radial nerve. That would be a possibility, or there is a possibility of axial artery injury and hematoma, and possibility of an intraneural hematoma may be another possibility. But the point here is it's only 24 hours. There is no need to rush here.
I will wait for it. Whether it is a delayed recovery because of an intravascular injection, that the nerve can retain the drug for long hours. Might be I can wait for another 48 hours. But if the patient is moving, but suddenly is not moving, the situation is different here. Because the motor blockade is proceeding. So it could be different. Now we have to remove the POP and look for any compartment syndromes or radial tunnel blockade or radial tunnel at the level of arcade of Frost. There can be because of the stretching of the nerves during the surgical practice. So most of them, because of paresthesia, the surgeons might implicate the anesthetist. But the problem most of the time is the surgical factors. Surgical factors could be due to stretching or due to compartment syndrome. But another important point, he is a young patient. He is not a diabetic hypertensive or any systemic disease. So the one thing is we have to look for a pre-operative screening for any neuropathy, or maybe brachial plexus injury sustained maybe due to trauma also is an important factor here. So if the patient has done what I have to do, I will wait for another 24 hours and immediately I can do an ultrasound, look for any hematoma, or maybe you can do intraneural edema or something, we can look for it. If there is nothing, you can do a sensory blockade on sensory as well as motor checking. If the patient could extend his elbow, that is you are lucky that the triceps and anconeus has been spared. So the problem might not be at the level of axilla, that may be due to at the level of the radial tunnel. So if the patient is like there is a distal block, how to map the sensory nerve? Most of the radial nerves, there is posterior cutaneous nerve of forearm, as well as the inferior lateral cutaneous nerve. All these things arise from radial nerve. So if the patient has any sensory blockade over the shoulder, or the level of blockade might be here. If the patient has a sensory blockade from the spiral groove from itself, because the inferior lateral nerve arises at the level of the spiral groove. So if he has a sensory deficit at the level of the spiral groove, could be there is involvement of inferior lateral nerve because the radial nerve could be affected at this point. But if the patient has a surgery deficit only at the web space, that could be because it can be sustained anywhere in the forearm. So by just doing a simple clinical examination and looking for other factors, we can easily rule what is the level and what could be severity. Most of the time it could be neuropraxia rather than axonotmesis and neurometmesis, but I cannot rule it unless I can do a nerve conduction study. But I will not rush for it. But I can wait and another 24 hours whether he recovers or not. And we can easily could have avoided by adding already said by doing a neurostimulation as well as injection pressure monitoring during ultrasound guided blocks.
So I think very nicely summarized by Dr. Rajaram. Number one, patient complaining paresthesia, like one thing is when the needle touched the nerve, did the paresthesia happen at that time, or when patient complained of paresthesia when you injected the drug? So these are two important points that we need to evaluate. When it touches the nerve, there is no damage. But when patient complains of paresthesia when you inject the drug, that's the problem. So this we need to understand, because in the literature, number one, first I wanted to share the chances of a neurological injury due to peripheral nerve block is extremely less now. That's number one statement. Number two statement, when it happens, we are not concerned about the needle going and hitting the nerve. It can never produce wrist drop. A needle going, even when you do with a blind technique, when the patient complains of paresthesia, you're pushing the needle inside, not injecting the drug, patient shouts, you remove the needle, it cannot produce a wrist drop, or it cannot be a neurotomesis or axontomesis. But what is more crucial and important is, after when the patient gets paresthesia while injecting the drug, then what actually it means is, inside the nerve, the first session, Dr. Rajaram sir gave an excellent explanation about the cross-section of the nerve. First, it is the epimysium, which is the covering of the muscle. Then you have the paraneurium. Then you have the epineurium. Then you have the perineurium, and then you have the endoneurium. So now, when you are pushing this needle, crossing the epimysium, crossing the paraneurium, crossing the epineurium, and you are going to inject the drug subepineurally, a large volume, in a closed compartment, then the biggest challenge is the intraneural pressure raises so much that the blood vessel which supply the fascicles, they get compressed and there is an ischemia. So what happens is an ischemic neuropathy, and it is not the mechanical injury that was caused by the nerve. So this is the first point that we need to understand in a nerve injury, that the drug that is injected is what produces a complication rather than the tip of the needle going and injuring the nerve. So this is point number one. And definitely, yes, it could be avoided by using an injection pressure monitor and using a peripheral nerve stimulator. That's the latest technique. But even in this case, what we need to understand is the wrist drop could always be also because of neurapraxia and surgical causes and stretching of the nerve, and not necessarily the block per se. And with the modern era, where we use a lot of adjuvants, when you use dexamethasone, for example, and you give a dense block. Now again, I come back to the same analogy. Based upon your skill sets, based upon the resolution that you see, the drug is either deposited between epimysium and paraneurium, or it is deposited between the paraneurium and the epineurium, or it is deposited subepineurally. Now, if it is deposited subepineurally, then the duration of the block is going to be really prolonged, because usually the block ceases, the effect ceases because of absorption of the local anesthetic into the venous side and getting into the circulation. But when it goes subepineurally, the venous return from that and the absorption of the drug is delayed, and the duration of the block goes for a longer time. As you rightly said, sir, 24 to 36 to 48 hours, you can wait for the neurological recovery. However, as it was rightly pointed out, any compression that is happening because of the plaster that has been applied has to be really checked to know the cause. And also beautifully narrated that the first thing that you need to do is to see and take the ultrasound and scan the nerve and see if there is a neural edema along the course of the nerve. And in places where MRI is available, MRI can be done to find out if there is a neural injury. Later phases, you can go for, as said, then you can go and see the nerve functioning, you can check. But this is a beautiful case scenario, and having said this, I wanted to share that in the literature, the incidence of nerve injuries is very, very, very less.
One more thing which we have to have in this type of scenario is the tourniquet which is being used by the surgeon. So the tourniquet pressure monitoring has to be done, because that can also cause nerve injuries.
I think communication with the patient and reassuring again and again is definitely vital at this point of time, because losing a limb and losing a function is definitely going to take a great impact on his mental health.
And it's a combined decision to examine this patient both with the surgical colleague and the anesthetist, because there are a lot of surgical causes, positioning of the patient. There are so many reasons why a nerve injury can happen, and it should be a collective responsibility.
We had a patient who came 2 years back when I was in Savita. We had a patient who came with a both bone forearm fracture, and one of my fellow in regional anesthesia, he gave a costoclavicular block. The same scenario happened. So what happened is he was not able to move the whole upper limb. So so it was there for 24 hours, and after we said we'll wait for another 1 day. But after one day, like, he started having flickering of movements, but not much movements, only finger movements were there. The whole left upper limb was completely, there was no movement at all, absolutely no motor power. So we immediately reassured him. We took him, we involved the surgical team, the neurologist, and because there was complete motor deficit, we immediately took him for a nerve conduction study also, but there was not much finding in nerve conduction study. So we put him on IV steroid for 1 week, and we started him on Vicelin and kept him for 4 weeks. After that, the power improved to 2/5 in 4 weeks, but still he was not able to move. And we again reassured, we felt sorry for whatever happened, and we followed him for 6 months. So, in 6 months, his power came to 3/5. That was the maximal power he got. But after that, he never came for follow-up. So this is one of the scenarios which we faced in our own institutions.
So again, possibly, as I said, if the injection has gone into the subepineurally, you would have produced an ischemic component. But as Dr. Prem mentioned, don't get scared. This is very, 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 very rare complication. And also, with the advent of ultrasound and with the using of a peripheral nerve stimulator and an injection pressure monitor, it's almost nil now. But that's a very, very rare case. But as I said, we want to equip with regional anesthesia. If you want to be an expert, you should also know the complications happening and how to prevent the complications. So the whole focus is on that rather than talking about the deficiencies of regional. In fact, I feel what RA offers to a patient is significant compared to the small issues that happen. But it's truly important that our mind knows what can happen so that you can treat it when it happens. Yeah, we move on to that.
Sir, we have talked about anesthesia-related factors and surgery-related factors. Can patient factors
Of course, yes. If the patient, I want all of you to read tonight homework before you come to the workshop tomorrow is double crush phenomena and triple crush phenomena. This is an excellent concept. What happens to the nerve in a patient with diabetes mellitus? And pre-existing neurological injury to the patient is very, very crucial and important, and they are more prone for developing complications. So please read double crush phenomena and triple crush phenomena. It's an excellent conceptualization on the patient reasons for having a neurological deficit following the block.
This is just for a comprehensive, this case scenario is just for to cover all the aspects of complications. So again, a young female having difficulty of breathing, facial puffiness immediately following an axillary block for a forearm fracture fixation, sir. So I request Dr. Rajesh sir to help us in diagnosing and managing situation.
So this is again a nightmare scenario, but it's very, it has been put up like anaphylactic reaction, but it is very uncommon nowadays when we use ester-based, when we use amide local anesthetics, because the previous era where there were ester-based local anesthetics, where because of the metabolic component PABA, they used to have a lot of anaphylactic shock or anaphylactic reactions. But nowadays it's very rare. But still, if this patient has developed the anaphylaxis, then we should take steps in the way of resuscitating the patient, starting from airway, breathing, and circulatory part. And very important drug which we have to use in this type of scenario is adrenaline. That adrenaline in 1 in 1,000 dilution, but it should be of very low dose, and that too is the one which is preferred route to resuscitate this type of patients.
Yeah, I agree. I think anaphylaxis is very, very rare, especially with the newer steroid-based local anesthetic solution is very, very rare. And I have never faced even a single case of anaphylaxis so far.
Because most of the hospitals use lignocaine test dose as infiltration because of that would have caused some, preservatives might have caused some anaphylaxis. That were stimulated this question. But using bupivacaine, there is no much of a question of anaphylaxis, I think.
Yeah.
Is it mandatory to give the test dose nowadays?
No, not necessary at all. Yeah, not necessary.
If they give antibiotics or lignocaine as a test dose, they think it's more anaphylactic.
So this evening session is Preeti anesthesia complication update. So don't get worried about this. We spoke about things which may never happen in your lifetime, but also we wanted to kind of sensitize you that this can happen.
Sir, I think I am very proud to stand in front of you, sir. I am sharing the dais with you. So it's a heartfelt gratitude for you to accept our invitation and channeling a wonderful
session, sir. I think we need a standing ovation from all of you, because this has been a wonderful 2-hour session
which was conducted extremely well moderated by our beloved Dr. Bala Venkata Subramanian, sir. Thank you very much, sir, for coming to our anesthesia update to our hospital and Madurai, sir. Thank you very much, sir. And I thank all the panelists, experts for their patience and in conducting the panel discussion, sir. Over to you, sir.
No, I think regional anesthesia has made a huge impact in the outcome. We see day in and day out in all of our cases. And India is the capital for diabetes mellitus. Diabetic foot is one of the common problems for which a patient comes to us. And majority of the times when they come in, sepsis has set in, hemodynamically unstable, ketoacidosis, and now the surgeon says that you have to debride the patient to give him the opportunity to live. And in this case scenarios, I think there's nothing like those anesthetists who know regional anesthesia to do very well. So here, the patient, when he has a diabetic foot, he's in the phase where all the end organs are involved. Definitely, he has got a peripheral vascular disease. That's why the patient has got and also sensory neuropathy. So there is an autonomic imbalance. Coronary arteries will be involved. Possibly the kidney, the nephropathy is there. So when they wanted a debridement, here comes the brilliance of an anesthetist who will not ask for hundreds of opinions and not do the case. That's the exterior anesthesia. The current anesthesia is knowing the technique and the technology, adopting it in clinical practice. Now you can't wait for his ketoacidosis to settle before you give anesthesia. If some anesthetist says, patient is in ketoacidosis, patient is in sepsis, patient has got hypotension, I can't give anesthesia, which means he is completely not updated with the latest. And the only solution for this patient to live is debridement and removing the source. So now, if we know a popliteal sciatic block administered very well with the saphenous component administered together, start the patient on what you need to do the medical management for ketoacidosis. The sepsis component to be treated to maintain the mean arterial pressure, you start noradrenaline infusion. A NORAD infusion correcting the acidosis, starting the patients on high-end antibiotics and giving a block, going for a debridement. In 2 hours' time, you have made a huge change between life and death. So this is the modern day practice of regional anesthesia. And I wanted all of you to embark on the journey to learn regional anesthesia. And I'm 100% confident that it completely changes the scenario. I would also request all of you, what we have learned in our institution over a period of time. Now we started doing the blocks almost now 25, 30 years ago. And now we have created pathways for every procedure. Hip fractures, when they come in, whether it's daytime or nighttime, there is a pathway. What you do first 3 hours, what you do next 6 hours, what you do next 12 hours. We try to do the surgical procedure within 24 hours because the outcomes are excellent. We do close to 4,000 hips per year. And on-arrival block is something we do for this patient. And because in our institution we work as a perioperative physician, there are 14 anesthetists on call even in the night. And we don't want to make a difference between the day and night for the patient. And hip fractures, the minute they come, they get a block. Now, even that we have standardized. So when you get a neck of femur fracture, you see whether it is neck of femur, whether it is intertrochanter, whether it is intertrochanter with subtrochanteric extension. And then you, based upon the osteotome that is involved, you decide whether to go for a suprainguinal fascia iliaca block, whether you have to go for a PENG block, or you go for a femoral block. So I request all of you to analyze and assess more and more of what you do in regional, become procedure specific, patient specific, and offer the best to the patient. Believe me, the minute you do an on-arrival block to a geriatric hip who comes inside, change that you make in him is phenomenal. Most of them come thinking that they will die. And they're in immense pain. They can't pass urine, they can't pass motion, they can't tilt themselves. It's in such an agony, and the minute they come in, within 30 minutes of coming into the hospital, if you make them completely pain-free, their heart rate comes down, the blood pressure comes down, they start sleeping, and you're changing the internal milieu of the patient and producing an excellent outcome. And similarly, we have devised the strategy of on-arrival block for all our trauma patients. They come in immediately blocked. And in fact, X-rays are taken only after the block is given, because otherwise when there is a crush injury, the patient, the orthopedic surgeons want an oblique view, a lateral view, an AP view. Imagine an injured patient with multiply, if they are going to change the position to take X-rays. So you would give the block and then do the X-rays. So these on-arrival blocks are a boon to our patients. I request all those who are working in institutions to discuss with your team to see whether you can bring in this on-arrival block as a concept and do it both in the day and in the night. And when you evolve strategies, it has to be safe. When you give it in the night, you also have to be prepared to treat the complications arising of the block, like local anesthetic systemic toxicity can happen. So there should be a defined block room with all that is needed for resuscitation. And I'm sure that the way regional anesthesia has grown and progressed, I want each one of you to embark on the journey to become an expert in regional anesthesia. And the new concept of enhanced recovery after surgery has an inherent component of regional anesthesia in it. Initially, cardiac anesthesiologists said, I'm only a cardiac anesthetist, I need not know regional anesthesia. But now, after the advent of the sternotomy pain being taken care by parasternal blocks, like pectointercostal plane block, completely revolutionized the extubation, completely has revolutionized the outcome. So there is no specialization in anesthesia which can say that I don't want to know regional anesthesia. Even neurosurgeons wanted awake craniotomy, and now we have progressed to subcortical monitoring and advanced neurosurgical cases, which needs regional anesthesia. So I think you need to invest a lot of time and truly become an expert in regional anesthesia. And I'm very happy that you have decided to do such a focused session on this, and especially upper extremity, because as far as a surgeon is concerned, he considers an anesthetist to be an excellent regional anesthetist if you are able to give an upper extremity block appropriately. Lower extremity block is not bothered because you know that you can manage with spinal epidural and all that. But whether you are an expert in RA or not, a surgeon decides only when he knows that you gave an upper limb block, it worked without you putting any other sedation, just with the block alone. And hence, I think this update is so crucial. And I wanted each one of you attending here to become a true expert in giving an upper extremity block. And tomorrow in the workstation, please focus. Once you have an ultrasound machine, I see most of you know interscalene, most of you know subclavian perivascular, most of you know axillary. I think the challenges are the costoclavicular block, the supraclavicular block, and identifying the phrenic nerve sparing blocks. Like I'm sure that you will teach upper trunk block, you will teach seeing the supraclavicular nerves, the intercostobrachial, and the anterior approach to suprascapular, axillary nerve block. I think all will be a part of the workshop tomorrow. And I wanted all of you to focus on it, repeatedly do it in your patients when you go back. Even if you don't put a needle, keep on scanning and make it yours. Make it yours, and you will make a huge difference in the outcome of your patients. And I'm extremely happy that all of you were very attentive, because the attention span was very good. And I think this is a good method to drive home points. If the same 2 hours, if it had been with 6 lectures, most of it, I know that you will be physically present and mentally absent. But here I could see, and I'm still not sure whether I'm wrong, but I hope I'm not wrong. But I could see most of you focused and very attentive. And I'm very happy that many of you have embarked on the journey to regional anesthesia. Age is not the criteria. When I was a postgraduate, we never had ultrasound machine. And many of my contemporaries and colleagues wouldn't have seen their ultrasound machine in the post-graduation, but doesn't mean that you shouldn't embark on the journey to learn ultrasound, because we do a lot of regional anesthesia fellowship program. Last year, when we got the application, we saw the application and our secretary brought it, and I saw the age. He was 74 years old, and he wanted to do 1 year fellowship in regional anesthesia. So I took up the number and I called him. His name is Dr. Kare. He's from Thane. And I said, sir, you applied for a 1 year fellowship in our hospital. He said, yes. Sir, did you mean to attend? He said, yes, of course. Why? Sir, no, you are just 74 years old. So he said, so what? I wanted to learn, and I promise you I will do night duties also. So I said, sir, that's okay, but we have an age limit. Then he said, Dr. Bala, please, before I die, I'm an anesthetist. I have never used ultrasound machine, but before I die, I want to do one upper limb block. And without giving sedation, the surgeon has to do surgery, and I will die peacefully. So this is my request to you. Even if you don't take me for 1 year, please allow me to come and work, observe, give me 1 or 2 chances, and I will do this, and then I will be a happy man to die. I was so touched that age was not the criteria, and I was touched with his emotions that he wants to do 1 proper block before his death. What a wish. And this kind of enthusiasm should be there within each one of us, so that we offer the best to our patients. And immaterial of the comorbidities, we can still devise a technique and use the technology to make it very, very safe. And for that, regional is very important. And I'm sure that each one of you will invest your time in learning more about this and become a true expert. And India will march towards an era where every single anesthetist will be literate in regional anesthesia, irrespective of the age. And I also take this opportunity to promote this with the permission of Dr. Balaji. I wanted to welcome and invite all of you for the next national conference of Academy of Regional Anesthesia of India to be conducted in Coimbatore between July 16th and 19th. Sorry to Ganesan, we never knew that the state conference is 1 week after that. When we decided this 2 years ago, we never had the state Tamil Nadu conference in mind. So we are doing this conference between 16th and 19th at Lee Meridian, Coimbatore. And one of the important components, this is a combination of Academy of Regional Anesthesia, Ganga Anesthesia Refresher Course, and the Anesthesia Patient Safety Forum of India. All the 3 meetings together, but single registration. And the way I have devised is, on Thursday, that is on the 16th, we have 48 master classes by some of the big names in the world. We have invited 100 international faculty. The first ever time that we have embarked on a journey to get the big names across the world to be here. And in a master class, it's 90 minutes. Like it involves target controlled infusion, it involves anesthesia for shoulder, anesthesia for hip, anesthesia, regional anesthesia for knee. If you go through the website www.awargarc2025.com, you will know it. So totally in those 4 days, we have 66 master classes, and that is to capacity build, to do hands-on on the patients. And we have 2 days of conference and 1 day of workshop, including 2 cadaveric workshops. So we have 17 workshops in several components of anesthesia. I take this opportunity to welcome as many of you as possible who have time. And as I said, we've got almost 18 faculty from United States, 14 from UK, 22 from Europe. Also, we have got from Canada, Australia, Africa, and Southeast Asia. So I wanted you to experience what the world thinks about. And we also have a separate track for point-of-care ultrasound. We have master classes, we have 2-day complete sessions, and we have workshops on workshops on point-of-care ultrasound. One complete track is on point-of-care ultrasound. Some big names from Stanford and Harvard are also involved in the point-of-care ultrasound. And also we have a separate track for chronic pain. And we have some of the big names in chronic pain come, including Dr. Samir Nerose, the president of American Society of Regional Anesthesia. We have got the president of European Society of Regional Anesthesia. So the point is to learn from them, and also for them to know that India has grown and progressed so much, because we have such good, excellent Indian faculty. So this is for those who want to do or doing chronic pain. Also, it's a great opportunity to be and witness some of the big names in chronic pain in the world today. So thank you, Dr. Balaji, for giving me an opportunity to welcome all those who are present here, and also request all the panelists who can get leave to be a part of this conference and to learn from each other. Thank you so much, Dr. Balaji. And thank you to all the panelists for this wonderful session and giving a lot of insights, practical tips, real-time experiences, because people generally don't want to discuss complication, and that's why a complication happens. And I'm very happy that we decided to discuss the complications. Thanks, Balaji, and thanks, Dr. Suresh, for this wonderful session. Thank you.
Thank you very much, sir. Thank you.